Hi, very good morning, everyone. 3rd May 2025, and we are meeting over here once again for a very, very important topic. Today we have Dr. Prantar Chakrabarti. He's a renowned consultant hematologist with over 29 years of medical experience and 15 years of experience in hematology. A former professor and head of hematology at NRS Medical College, Kolkata. He specializes in thalassemia, bleeding disorder, bone marrow transplantation. He is widely recognized for his academic contribution and prestigious fellowship like in Royal College of Mary Cure Fellowship, currently on sabbatical in ruler of Tamil Nadu. He is consultant hematology in Zoho Corporation in a village called Tenaski. He's a founder and CEO of Choho Mentor Academy, Mastermind, Cybernetic Care. Sir, over to you.
Thank you. So, good morning, good afternoon, good evening, wherever you are. And it's my pleasure to join today. I'll just share. Yeah, I think it's visible and you can hear me, right? So, we always in medical science talk about the tip of the iceberg because whatever we see, most of it remains hidden here. But this chip, I'll tell you what it is and, how it is baffling us, is more than a tip. So I call it chip of the iceberg. And this is my contact details. So I start off with a patient. This is one in US, a 73-year-old man who is an emeritus professor of oncology at a major medical school. He already had read several papers about clonal hematopoiesis, and then he asked his primary care physician to test him for clonal hematopoiesis. So obviously, the primary physician had to agree with this emeritus professor. He had a normal complete blood count other than a slightly abnormal red cell distribution width of 15.3% when the cutoff was 14.5. Nothing much. So you think, why would you do it? But anyway, he had read about CHIP. Primary care physician deferred to the oncologist's perceived broader knowledge base and ordered a gene sequencing panel for common chip-associated genes. And then, lo and behold, a DNMTA P.R882H mutation was detected at a variant allele frequency of 7%.
It's good that hour is okay. If not, I would transfer.
Yeah. So 7% means it is significant because for all these disorders, we are taking the cutoff at 2% at this point of time. We might change the threshold in future. So it came as positive. And then the primary care physician as well as the emeritus professor did not know what to do. So I'll take you through the journey and then tell you at the end what was done with him. So CHIP is basically clonal hematopoiesis of indeterminate potential. We have certain terminologies in medical science, idiopathic. I think it is idiotic for me and pathetic for the patient. And then we also have monoclonal gammopathy of undetermined significance. That means we do not know. So here is another where we are using the term indeterminate. Means we do not know what is the potential. So we are not calling it cheese, we are calling it chip. Then you have something called CHUD, right? Again, clonal hematopoiesis with unknown drivers. Drivers means the mutations. I'll discuss about them. And then you have something called ARCH, which is age-related clonal hematopoiesis. And then, this is not the end. You have something called cytopenia, clonal cytopenias of undetermined significance. So just like MGUS, you have clonal cytopenia of undetermined significance. And then you also have ICUS. So there are a lot of terms floating around. First, I'll start off with what is clonal hematopoiesis. We always talk of age-related clonal hematopoiesis. Age-related, why? Because as people age, their tissues accumulate an increasing number of somatic mutations. Remember, these are not germline mutations which have been transmitted from our forefathers. These are somatic mutations. While most of these mutations are of little or no functional consequence, sometimes a mutation may arise that confers a fitness advantage on a particular cell. So it has a mutation, and then it actually has a survival benefit and overrides other normal cells. Now, when this process happens in the hematopoietic system, in the stem cells, a substantial proportion of circulating blood cells may derive from a single mutated stem cell. Because, stem cells have this power of regeneration. So, this outgrowth called clonal hematopoiesis is highly prevalent in the elderly population. And by the time you are 70 years, you remember the age of the emeritus professor, you are likely to be harboring it. Remember, there's one protein coding mutation every 10 years per hematopoietic stem cell. So imagine the number of cells you have. So you have around 50,000 to 2 lakh or 200,000 hematopoietic stem cells per person. So imagine 200,000 every 10 years, they are being mutated. And your age is, say, 70. So these are the number of mutations you can get, right? So by age 70, an average person will harbor 350,000 to 1.4 million protein coding mutations in his or her hematopoietic stem cell pool. But don't get alarmed, we all are having it. But is age the only cause of this mutation? No. It is a predominant cause, but others are associated with it. Smoking. So this has been demonstrated to have 1.5 to 2 times more mutations. Cancer therapy. So there has been this study from Memorial Sloan Kettering Hospital called SLK Impact. They have shown sometimes it can be even 10 times, depending on what chemotherapy you have used or what radiotherapy you have used. Metabolic disease, obesity, right? So we talk of lifestyle diseases. This can also lead to mutations. And then we call something as inflammasome. So inflammation, whatever be the form, be it infection, be it autoimmunity, be it others, even stress causes inflammation. So this can also. And then unique environmental exposures, like say the 9/11 attack, the first responders, they have been checked. They have a higher incidence. Firefighters, even people who are awake the whole night, they also have this. And though these are somatic mutations, sometimes there are certain germline variants which also predispose. So it's a multifactorial thing. And you'll realize if you're smoking and if you're aged and you have obesity, then all this will contribute together. But is the weightage the same? I'll come to that. So let me explain to you what happens when you're an adult. So there are certain pathways by which the hematopoietic stem cells, they are in the perivascular niche and in the endosteal niche. They actually come out from the endosteal niche and come to the perivascular thing. And then inflammation does something. What does it do? It makes the pattern skewed. So there is deficient clearance of neutrophils. There is senescence and decreasing support of the PCs. There are megakaryocytic skewing. Neuropathy can occur due to arterial attrition, bone and niche remodeling. And you have more myeloid-based hematopoietic stem cells than lymphoid-based. If you have a lot of fat cells, there's some adipogenic differentiation mediated by interleukin-1 beta. So these are the normal effects of inflammaging, means aging combined with inflammation. So there are certain drivers, I'll not go into the names. Now, with this inflammaging and this particular skewing, what you have is alteration in your immunity. So altered NK cell function, immune modulation, and then there are certain inflammatory signatures, and there is angiogenesis, which can lead to atherosclerosis, osteoclastogenesis. These then get a clonal advantage, and then when you analyze the cells, you see that, DNMT3A mutated, TET2 mutated, these are there. So at birth, there are certain mutations, right? But it's myeloid, lymphoid is around 50-50. By middle age, you have less stem cells, you have DNA damage, telomere shortening or telomere attrition, epigenetic dysregulation. And then with inflammation and with aging, this is what you get, right? There are so many mutations, and this can lead to a number of things. This is internal, right? This is happening. So now we actually talk of something called exposome. So what we are exposed to from our mother's womb till our death. And then if you give intensive chemotherapy, like which can affect the TP53, or there is autoimmunity, there is immune evasion or myeloid malignancy, you can get post-chemotherapy, radiotherapy, myelodysplastic syndrome, and AML. Now, this we knew for a long time, right? We called it secondary MDS or AML. So when you're born, you're young, no somatic mutation, then you have some low frequency mutations, and then you have CHIP. And then if you think, okay, they will develop some hematological disorders. That is not the truth. Cardiovascular complications, and let me tell you, in the last 2 years, cardiologists have published more about CHIP than hematologists. You go to any cardiology conference, you'll always see they're eating chips and discussing chips. And then hematologic malignancies, the risk can be as high as 10 times. So what are the relative frequencies of the mutations? In age, the commonest is, as you can see, DNMT3, right? This professor also had the same. This remains, but as you can see, with smoking, you have ASXL1 mutation, which is more. And then when you have elevated cholesterol or your fat, you get more TET2. And then germline variants also, you get more TET2. And these actually determine what kind of mutations will ultimately be there. And remember, they do not work in isolation. So they work together, and we have done all types of gene expression studies. I'll show you some results. So the commonest, as I told you, are DNMT3A and TET2. They have the mutant progeny. JAK2 is a downstream mutation in, JAK2 plays a very important role in myeloproliferative neoplasms as well as in rheumatoid arthritis. So you use JAK inhibitors there. Now, this is happening in the peripheral blood. If you look at the cells carefully, you might see certain changes, you might not see. And then there are certain epigenetic changes. So enhanced expression of pro-inflammatory interleukin-6, interleukin-1b, pro-inflammatory T cell polymerization, increased neutrophil entrapment formation, enhanced thrombogenesis, leading to ultimately atherosclerosis, aortic stenosis, accelerated heart failure. So imagine, the mutation is happening in the hematopoietic stem cell. The effect is on the heart. That is the beauty of CHIP. And then there is a selective advantage. Some get selected. Inflammation also plays an important role here. So if we look at a visual abstract, you'll see that there is a germline risk, which we are harboring. There are certain sex differences. Males are worse off, as always. Genotoxins like smoking, radiation, chemotherapy. And then normal, then you get acquired mutation, low abundance clones. We call them microclonal hematopoiesis, micro-CH. And then because of survival advantage, the growth rates, the acceleration rates are not the same. Some mutations grow at a steady rate, but there are certain spliceosome mutations which occur later in age. They grow at a rate of 50%. So you can imagine there is a threshold. It was going like this, and suddenly it goes like this. And the non-malignant outcomes are actually more cardiovascular disease, as I told you, COPD, CKD, rheumatoid arthritis, osteoporosis, thrombosis, DVT, cardiac disease, and all those. But there's one positive aspect. There's a decreased risk of Alzheimer. So, people say if you smoke, you can get less Alzheimer. It has not been proven, but we do not know whether this mediates. Now, what is the pyramid? So first clonal hematopoiesis occurs. Part of them, say 1 to 5%, get chipped. Part of them get cytopenia. Cut of them get MDS AML. And then you have ECAS, EDAS, which EDAS means basically dysplasia of undetermined significance. And this is cytopenia of undetermined significance. And then if you look at the dysplasia, depending on the variant allele frequency, it can be as high as 50%. The dysplasia is all over the place. So CHIP gains dysplasia, goes into CICUS, and then goes into MDS. Just to give you a diagrammatic visualization. So what is the definition of CHIP? Presence of at least one somatic mutation that is relevant clinically and otherwise also found in myelodysplastic syndrome or other myeloid neoplasm. So not all mutations, right? That is relevant clinically, and I'll show you who those are. But there should not be any cytopenia, persistent cytopenia. Because if there is cytopenia, then it becomes CICUS, ICUS, and all those things. And exclusion of MDS and all other hematopoietic neoplasms. So once you have myelodysplastic syndrome or AML, then obviously it is not CHIP. Because in CHIP, you do not have those problems. Now you have idiopathic cytopenia of undetermined significance. Presence of relevant cytopenia in one or more lineage for at least 6 months. This is important because, any viral infection can also give you transient cytopenia. It is not explained by any other disease, diagnosis of exclusion. And again, the diagnostic criteria of myeloid neoplasm should not be fulfilled. Clonal cytopenia of undetermined significance. So remember here, there was no clonality, right? It was just idiopathic. If there is a clonality, presence of one or more somatic mutations, otherwise found in patients, just like CHIP, and the allelic burden is more than 2%, then it becomes CICUS. Here, it is not 6 months, 4 or more months in one or more peripheral blood cell lineages. Again, if it's a myeloid neoplasm, then it is not CICUS. It becomes MDS. And you have to exclude all other causes of cytopenia and molecular aberration. So again, a diagnosis of exclusion. So if you are wondering, what is the difference between CHIP and CICUS? Now, for diagnosis of CHIP, the current cutoff for variant allele frequency of the dominant clone is more than 2%, because there can be more than one clone. And they are saying that if you get cytopenia, some groups like this one have proposed that if the variant allele frequency is more than 20%, it has a higher chance of cytopenia and it becomes CICUS. Now we are talking of clones, right? I'll take on the garb of a molecular biologist for 5 minutes. How do you detect the clone? So you've all heard that now you have next generation sequencing. So what was the first generation? This was the classical sequencing where we used ultimately a capillary electrophoresis. Second generation was we developed our libraries through information from the Human Genome Project, and we were using pyro sequencing, ligation, and then reversible dye terminator. And then you have third generation or next generation, where you have fluorescence detection and direct inspection through tunneled emission spectra. And now you have Oxford nanopore, which is quite effective. And you have DNA transistors. This is where the most of the development is going on. So we are trying to reduce the cost, and we are trying to reduce the turnaround time. So if you look at PacBio-RS, the runtime is 2 hours, okay? And there are certain Illumina MySeq where it is 27 hours. Sanger sequencing used to take 14 days. So what we are doing is we are trying to bring down the error rate. We are trying to bring down the TAT, but we are also trying to bring down the cost. So MISEC would cost you $125,000. Genexus will cost you $288,000, whereas Nanopore costs you only $1,000, right? So you can do targeted sequencing, you can do whole genome sequencing. It depends on how you want to proceed, and there are ways of doing it. And then you must have heard of whole exome sequencing, whole genome sequencing, and then certain targeted sequencings. So the most sensitive is ECS, where you can detect a VAF of 0.01%, right? Clone sequencing. But the problem is, do you need this kind of a sensitivity? There's a lot of debate in the molecular biology world. So if you do targeted, you will detect lower fractions, but you might miss some. If you do whole genome, which I'm showing here, then you can catch hold of them. And this has been beautifully explained by Siddharth Jaiswal's team in Blood in 2020. So whenever you're looking at a mutation, patients bring me a lot of printouts and then tell me, sir, please interpret this. I said, I never ordered it. Now, ask the person who has ordered it to interpret it. Because in this kind of high throughput data, it is GIGO, garbage in, garbage out. Then factors which can affect the prevalence of detected. What was the sequencing depth? What was the set of genes sequenced? Minimum percentage of blood cells with the mutation. If there's already cytopenia, then your cell yield might be low. And then you include controls that account for background mutation rate like germline variation and sequencing artifacts. So you need very thoroughly trained bioinformaticians who can help you interpret it. And then you have the chip associated mutation, you have the clonal advantage and risk of blood cancer. Lymphoid actually does less damage. Megakaryocyte erythroid along with inflammasome leads to more damage. Now, what are those mutations I told you which are significant? The commonest, as I showed you, is DNMT3A. Then you have TET2, ASXL1, which is also present in AML, PPM1D, JAK2, present in polycythemia vera, myelofibrosis, SF3B1, which you know is present in sideroblastic anemias, TP53, notorious for all sorts of cancers, GNAS, GNB1. And this list is increasing. So depending on the clinical setting, you cannot just screen any person. If you're suspecting aging associated, you should look for these mutations. If there's a history of chemotherapy or radiotherapy, then you should look for TP53 and PPM1D. If a patient has aplastic anemia, then you should look for ASXL1, BCOD, DNMT3A. If there is severe congenital neutropenia or, these are the inherited bone marrow failure syndromes, you should again look for TP53, CSF3R. If there is unexplained monocytosis, in India it is quite common because of TB, you rule out TB and then you look for these mutations. So depending on your clinical scenario, you should order for the mutation study. Now, if I have not confused you enough, I hope so, you must understand that clonal hematopoiesis is when there are clonal disorders. If there are unknown drivers, not known mutations, you classify them as CHUD. If there are known drivers, see what is the variant allele frequency. Is it more than equal to 2 or less than 2? If it is less than 2, it is micro. Then once you look at the VAF, then divide them into myeloid and lymphoid. So now myeloid is not called M-chip. It is just called chip. Lymphoid is called L-chip or driving mutations LMC. Now LMCA can lead to L-chip, LMCA or ambiguous MCA, which can be myeloid or lymphoid. And then within myeloid, I've discussed CHIP, I've discussed CICUS. This is the current understanding we have. Now, what are the effects? I told you hematological, thrombosis, MDS, AML, even lymphomas. But non-hematological, right? Atherosclerotic coronary vascular disease, heart failure, which can be ischemic, high ejection fraction, low ejection fraction, non-ischemic, even COPD, type 2 diabetes. Imagine. So now you have another angle to the diabetes story. Now, there have been certain studies like using whole exome or SNP arrays, and you'll see that hematologic malignancies in pre-existing have been as high as 31-42%, right? And there have been lymphomas, plasma cell neoplasms, chronic lymphomas. And in this particular study, they did a different kind, so they didn't get enough. So slowly, this was discovered way back, 10 years back. And they thought even in rats, mice, there was increased cardiovascular mortality. And then slowly with research and research in hematology and cardiology, we now know that clonal hematopoiesis predicts what kind of heart failure you can have below the age of 65 years and a worse outcome in cardiogenic shock, regardless of whether there is ischemia or not. So you have a definite risk of heart failure. They have been observed in different parts of the body, observed in the brain, and even, as I told you, in diabetes. So what do you tell your patient? There have been two clinics which have been running in US. One is in Stanford, the other is in New York. So where do they get these patients from? Not from the hematology clinic. They get it from, say, you're doing a germline DNA testing in a newborn and you get somatic mutations on your radar. You are evaluating a non-myeloid neoplasm, even a solid tumor, you get these mutations. Non-neoplastic conditions, you cannot explain the heart failure. You look for mutations, you get these patients here. And then you get a cytopenia, you look at mutations, you get it. And the most dangerous thing which is happening now, genome putri and all this, genetic testing done in a healthy person on a research or clinical basis. And then you get them. You say they have CH, right? You have to explain to the patient, and then you have to refer to the cardiologist, to the medical geneticist, to the social worker, psychologist, or psychiatrist, because counseling is most important. Some of them might think they will die tomorrow. And then in US, financial counselor for advice on insurance. Insurance, which is always sitting there so that they don't have to pay you. They'll say, you had a pre-existing condition, CH. We will not pay for any of your diseases. So in the future, other medical specialists might join this team, like nephrologists, neurologists. Neurologists are already there to some extent, but cardiologists are surely there. So today, if you get a peripheral blood cytopenia, and this is, if they might not be referred to a hematologist also, you rule out secondary like nutritional deficiency, drugs, immune-mediated, autoimmune. At least look for anti-nuclear antibody. If you get it, treat the underlying problem. If you don't get it, look at whether there is dysplasia. If there is already dysplasia, it becomes a myeloid neoplasm because this is what we call MDS. But there is no dysplasia. You do a clonality study by FISH or, single nucleotide polymorphism array, you get it, they still become a myeloid neoplasm. But now you use a more sensitive technique like NGS and you get it. If the variant allele frequency is more than 20%, I suggested CICUS. This has not been accepted by World Health Organization. If you get nothing, no clonality, but the cytopenia persists, idiopathic cytopenia, right? So there are certain protocols. They collect blood and urine samples at NIH, heart activity monitoring testing, ultrasound of neck arteries to look at Doppler atherosclerosis, liver and heart scans, bone mineral density scan, lung function tests. We do not know if we do it in an unscreened population, what is the benefit? They sometimes do a cheek swab or skin punch biopsy, optional advanced heart and full body scans. For monitoring this, you have to do bone marrow and peripheral blood counts twice a year. No patient, especially if it is not a patient, they will agree. NGS once a year, right? Imagine the financial burden. So how do you monitor it? Bone marrow, peripheral blood, if you can't do it twice a year, once a year or once in 2 years, if it's not MDS or AML, they are proposing NGS testing once a year. But in hematologically asymptomatic individuals, no further testing, please. Like in this professor, which I discussed, he didn't have anything. You need not monitor him. And how do you re-stratify them? So it is called a CHR score, right? Clonal hematopoiesis risk score. And there is an app where you can put in all this data, which includes even red cell distribution rate, mean corpuscular volume, obviously age, because if you're more than 65, 1.5 scores. And whether it's a high-risk mutation or not, because this was published in New England Journal and they showed that actually it can differentiate between CICAS, chip, and no chip CICAS, and this is high risk of going into AML and other neoplasms. So you just go through this score and do the scoring. There should be a clinic for this, but we do not have resources in most of the countries. But remember, based on whether they got chemotherapy, radiation, or germline predisposition, or the person is a smoker. So one thing you can advise your patients, stop smoking, right? Now, how much reversibility is there? That we are still looking at the cohorts. Because you cannot avoid chemotherapy, radiation if there is a malignancy. You cannot change the sex, though they are doing it nowadays, but the genetic makeup does not change. You cannot change the germline disposition. So the only thing which decreases is Alzheimer. All other risks are increased. So what happened to our knowledgeable patient? The emeritus professor who had a DNMT3A mutation, 7% VAF, has struggled with fears about his future, right? If he did not know it, ignorance is bliss. And he has advised several of his colleagues not to undergo genetic testing. I think which is the right thing. If you are not symptomatic, if your peripheral blood is normal, sometimes it is better not to know. But then you can tell me, if I get a patient like this today, what will I do? Very simple. You do a cytopenia workup and management, and then you put the data into chrsApp.com, depending on whether it is high risk, intermediate risk, or low risk. High risk, every 3 to 6 months CBC, repeat NGS annually, repeat bone marrow with clinical change. And in the CBC, an experienced hematopathologist should look at the dysplasia. Consider risk benefits of clinical trial. Low risk, just do CBC and dysplasia study, NGS with clinical change only, and bone marrow with clinical change only. If there is no clinical change, no use doing all those tests every year. So you should refer them back to primary care provider or the preventative cardiologist. They will tell them that we will monitor you. Other subspecialists may need to be involved. So I hope that I have not confused you. I have tried to tell you all the data which has come and how you tackle the chip of the iceberg. Thank you very much.
Thank you, Dr. Chakrabarti, for the wonderful presentation. Now we will open the forum for the question answers. Dr. Chong, please go ahead.
Thank you, Dr. Chakrabarti. This is very, very fascinating. And I like the part that you tell us that actually this chip has confers an advantage evolutionarily on the evolution basis. That's why it proliferates and it exists. That was something I was not aware of. So That was very, very interesting. In Singapore, recently, with so much interest because, sorry, I'm outside, it's a bit noisy. But because we have a company here called Lucence that has been introducing multi-cancer screening tests. And one of the tests that they do is a chip signal. So we have had patients with chips, and that's why, this is a whole new area. And as you said, it extends into cardiovascular risk, diabetes, inflammaging, and so on. So it's been a very, very hot topic in Singapore currently because of this situation. Thank you.
Thank you.
So do we have any other questions on the forum? Please go ahead. Monica, you want to say something?
Sure, that was a fantastic presentation, and it brings all of us to where medicine is today. And I think a topic that applies to every single person. And you were so elegant in how you presented it that we have to think of pragmatism, using the case study that you did, about how much are we willing to keep finding and searching, and what do we do with the answers that we get. And I don't think we're there yet to have that database to give you the positive predictive or negative predictive values of each of those test results. I think when we have a more robust database, the analysis will be better. Otherwise, we end up sitting with a lot of results and a lot of anxiety as to where to move forward. But I think in situations where you can use this, as if you say, okay, I have an abnormality on my chip analysis, and what are my modifiable risk factors? As much as we can avoid even environmental tobacco smoke, even if we don't smoke ourselves, or be cognizant of other risk harm reductions, such as avoiding the use of non-stick pans, using non-highly ultra-processed foods in our diet. I think that maybe it might be a wake-up call and say, okay, maybe I need to lose that extra 10, 15 pounds, or I need to do something else. So it's an incredible presentation on an incredible topic. Thank you very much. That's what I got from it. Thank you.
Thank you.
Dr. Chakrabarti, I think in Singapore, we are thinking, or rather the hematologists are actually thinking of running a chip clinic, as what you said.
Yeah.
So that will be quite challenging. As you said, it's a multidisciplinary approach. So definitely there's a lot of interest in this area. But again, like I said, the cost here is quite staggering. I mean, the cost price of the multi-cancer screening Singapore, the cost price is somewhere close to $2,000 to $3,000. So it's a staggering cost. So quite challenging in that sense.
Yeah. I think Dr. Angelique has a question.
Yes, Dr. Angelique, please go ahead.
Yeah.
Morning. This was a very good presentation, but I just need to know from a practical point of view. I'm sitting in the surgery. I'm doing my yearly screening on my patient. On my full blood count, what do I need to look out for to alert me that maybe there's something going on? So I'm not at the chip at this stage. I'm just at the normal, ordinary full blood count. What do I need to look out for? Thank you so much.
Yeah. So in the complete blood count, the most important information is the mean corpuscular volume, MCV. Previously, we said, okay, when you age, you get a macrocytosis. Now we know that there is something going on. So you look at the MCV, you look at the RDW, and you look at the peripheral blood smear for dysplasia. So dysplasia is not objective at all, but this is something which you should look for. Any kind of cytopenia, right? Because as I told you, with aging, you have a skewing towards the myeloid thing. And even in Singapore, there have been several single cell genomic assays which have shown that actually this skewing towards myeloid leads to a lot of hematological neoplasms. So complete blood count, no cytopenia, no dysplasia, normal MCV, normal RDW, do nothing, right? But if there is a suspicion, and especially if there is cytopenia, this is when you should put your thinking cap on. Is there something else? So you'll obviously first rule out folate in our country, in India, folate deficiency, vitamin B12 deficiency, and then people take a lot of non-prescription medications, some Ayurveda which contain heavy metals. So we have to rule out all those things, and then you look at. But my patients, sometimes the problem is that they get this full report, and then they say there is the commonest thing which I read is variant of uncertain significance. Now, what do you do with that? So that's why I showed you, we know which are the significant ones. You only order them, and I showed you a table from blood journal that depending on the background, whether that person has received chemotherapy or radiotherapy or has an inherited bone marrow failure syndrome, you ask for a particular set of genes to be analyzed. And then if you get it, if there is cytopenia, then monitor them. If there is no clonality, just follow up the cytopenia like we hematologists do. We give some B12 folic acid and reassure the patient. So this is what you will do. But the most important thing which we all physicians should understand is we should not create panic in the mind of the patient, because that leads to more harm. There will be more inflammation, more stress, and we do not know what will happen to those genes. Thank you.
So there's a question where somebody's asking where does this condition increases my risk of other diseases like heart problems and others?
No, per se, heart problem due to other causes do not. It's basically the cause and effect relationship has now been established between CHIP and atherosclerosis, right? So in an atherosclerotic population, especially for research purposes, if you do it, significant percentage you'll get these somatic mutations. Okay. But if I have say a rheumatic heart disease, which is fortunately going down, or if you have age-related aortic stenosis or other things, there might or might not be. But because all of these things are linked, so diabetes, syndrome X, metabolic syndrome, atherosclerosis, so then you can get some link, but your approach does not change, right? You will manage the heart failure in that manner only. But you will understand that these patients need more frequent monitoring. So that is what is happening. If you look at the cardiology publications, I mean, you cannot change those mutations. It's only that you have to be more vigilant, and you have to understand that this patient has a higher risk of cardiovascular death. So I will frequently monitor them, maybe by digital health aids, or they did not come every time, but I will put them in that so-called high-risk category. Now, as far as hematology is concerned, unless it is high-risk CCUS, which has a predilection for progressing, for others, I will not do anything. Like in MGUS also, I'm just taking from my myeloma colleagues, MGUS low risk monitoring is different. MGUS high risk monitoring is different. Smoldering myeloma monitoring is different. So it's just that there is something smoldering there. Depending on what the risk is, you monitor them, but it's not that you can do something great. But if you can go in for some hypomethylation or certain other drugs which are now being tried, to actually there are monoclonal antibodies being developed, looking at these mutations and being targeted, maybe even small inhibitory RNAs in future, we might be able to do something. But we have not reached that stage till now.
Okay. So can diet, exercise, supplements help to slow progressing of this condition? And should I be worried about my family members or passing this risk to the children?
I think diet and lifestyle definitely have an effect. This was known for thousands of years. It is just that we have understood that what they do. So the three things you need to understand is you should eat less and eat as much as natural as possible other than ultra-processed, sleep well, and move. Because you cannot run today's software, where you sit all the time. in a hardware which is 2000 years old. Your body will actually protest, and this kind of things will go on happening.
So in fact, I think diet is something which is a problem for a lot of diseases.
Yeah.
So so second question in this was, do I need to be worried about my family members, and can the risk be passed to my children?
Yeah, so these are not germline mutations, but certain germline mutations predispose, right? So this DNMT3A or TET2 and all, these will not be transmitted. So don't worry about it. But we do not know why some people are more predisposed to inflammaging, maybe of telomere shortening. So we do not know, but obviously what our teachers used to tell us, if there is a history of young stroke or young AMI in the family, all others should be careful. That remains. Because that is a phenotype detection. We are just trying to get a genotype correlation with that phenotype.
Okay, and how often one should do the blood test and the checkups?
1 year, if you do not have a problem.
Okay.
1 year. And that's why I tell, please, all the physicians who are listening to me, do not write hemoglobin TCDC. It has died 25 years back. Ask for a complete blood count, which should include a peripheral blood smear examination.
Yes.
Anyone else have a question over here? If not, sir, then we would like to have a closing statement from you and a take-home message for doctors and general public who are watching it. So,
see, we are learning a lot of things. And today, in the age of, so I tell now we are in AD, right? We were in BC. So what was BC? BC was before ChatGPT. Now we are in AD, that is after DeepSeek. Now you have to realize that there is a lot of information, but that has to be crystallized, and we have to make sense of all that information. That's why I call it the tip of the iceberg. We're just understanding it. Don't get panicked, and don't unnecessarily, I'm telling again, if you're healthy, you do not have a problem, don't go for such tests. Okay? Even if you have a lot of money, please donate it so that others get benefited in terms of healthcare. You donate it for prevention so that people exercise themselves, people have a healthy diet. And then let us try to make sense of what is happening. Let us use our brains. We have the most important tool between our eyes. No lab instrument, the latest next generation single cell sequencer also is equivalent to what we have here. Use it, and we will slowly become a better human race.
thank you so much for kind words. And I think I'll steal that statement. It was very nice before ChatGPT and after DeepSeek. So I think that's a very good statement to end this. If we don't have any other questions on this forum, we would like to take a leave. And it was a wonderful and interactive session. Dr. Chakrabarti, we would like to invite you again for this forum. Dr. Chong, your closing remarks.
Thank you, Dr. Chakrabarti. It was an amazing discussion today. And this topic is really, really, as you suggested, the tip of the iceberg. I like your analogy about the fact that we are having a 2000-year hardware and a new software. So I look forward to hearing you again when there's an update on chip or the relevant topic to it. Thank you very much, and most kind of you to inform us of this latest developments. Thank you so much.
Thank you.
So with this note, we'd like to close the session. Thank you everyone for joining in. See you again for next session. Thank you.
Bye.